This is the Carbohydrate Metabolism and the Diabetes Mellitus tutorial presented by the SchrDbb. Reference Chemical Pathology Lecture Note of University of Cape Town by George Van der Waart. So here you're going to visualize the overview of carbohydrate metabolism. On the overview, you need to know that what insulin synthesis, secretion, and the metabolic action. You need to know that you're going to have insulin secretion, metabolic action of insulin, all that are going to be seen in this tutorial. So you can just visualize this as a quick glance to know the outline of this chapter. This chapter has been written by the Dr. Peter Behrman and Prof. T.S. Pillar. So now, after the learning objective, you're going to have the overview. Let's start with the overview. Now we need to know that what the major processes in glucose metabolism. At the beginning, in glucose metabolism, you first have glycolysis. Is it clear? Glycolysis in glucose metabolism occur at the level of the cytoplasm, and also at the level of the cytoplasm can have gluconeogenesis. Glycolysis is the conversion from glucose till the molecules that are going to be used to produce ATP in the Krebs cycle. So you can have glucose converted in the cytoplasm to produce by glycolysis, and is going to enter the Krebs cycle in the mitochondrion. Also, the molecules from the Krebs cycle can move vice versa to produce the glucose, which can be produced glycogen. Is it clear? So to produce glycogen from glucose, it is glycogenolysis, and to produce glucose to produce glycogen from glucose is glycogenesis. To produce glucose from glycogen is glycogenolysis, and to produce glycogen from glucose it is glycogenesis. Now, these are the different molecules which are located. The major molecule of glycolysis. The major molecule of glycolysis is going to be lactate. It's going to be pyruvate. Now, pyruvate is capable of entering the Krebs cycle as acetyl-CoA. So pyruvate can enter the Krebs cycle as acetyl-CoA to produce a different molecule. Also, if there is anaerobic respiration, pyruvate can produce another molecule of ATP by converting to lactate. Is it clear? And also pyruvate can convert to produce oxaloacetate. Is it clear? Now, the different enzymes involved here, to convert from pyruvate to lactate, use LDH, which is like lactate dehydrogenase enzyme. To convert from pyruvate to acetyl-CoA, we use the PDH, which is pyruvate carboxylase enzyme, which is pyruvate dehydrogenase enzyme. And to convert from pyruvate to oxaloacetate, it is the pyruvate carboxylase enzyme. Now, we need to know that what insulin is probably the most important hormone regarding carbohydrate metabolism. Is it clear? So that is, you need to know that is the role of insulin, and insulin is mostly involved in reducing the glucose content of the body in any result. So insulin is going to try to make sure that the cells of the body uptake glucose. They are going to make sure that the glucose is going to be converted to produce glycogen. They are going to inhibit glycogenolysis and glycolysis. They are going to inhibit gluconeogenesis. So those are the role of insulin. Now, depending on factors like prevailing oxygen availability and cell status, pyruvate can follow these three possible routes. Is it clear? As you have just seen. So, like oxygen in content. So you can do anaerobic respiration. In case of anaerobic respiration, the lactate dehydrogenase can act on the pyruvate, as you have seen on the diagram, to produce lactate. So the next one is that in the case of a Krebs cycle, you can when it enters the Krebs cycle, you can produce, it is converted to acetyl-CoA in order to enter the Krebs cycle, and the enzyme has been shown up. Now, the formation, it can also be involved in the formation of the oxaloacetate by the pyruvate carboxylase, which is a substrate now of gluconeogenesis. Now the next now is formation of, so all these molecules were just involved in these cycles here. Now the next is the formation of lactate is a metabolic dead end. So when you have formation of lactate, it's a metabolic dead end and the only possible fate of lactate. That just means that what, when immediately that pyruvate is converted to produce lactate, lactate cannot be converted back to pyruvate except at the level of the liver. So the muscle cells cannot produce pyruvate from lactate to such that it can go back to glycolysis. So immediately it's converted to lactate, there is no other, it's a dead end. It means that it cannot be converted back to pyruvate. It's only going to be converted back to pyruvate at the level of the liver. Is it clear? So during the Cori cycle now, exercising muscles now releasing the lactate into the bloodstream. Is it clear? And now that is going to subsequently be taken at the level of the liver, which is going to be used there now for gluconeogenesis. Is it clear? Now the protein catabolism provide amino acid. You need also to know that what the protein catabolism is also going to provide amino acid that is going to further metabolize to yield the various metabolites that are going to be in the glycolytic and the Krebs cycle. Is it clear? So amino acid can also come from proteins that can be helping in the Krebs cycle. The next, you have the breakdown of triglyceride is going to provide little substrate for gluconeogenesis. Triglyceride provide only little substrate for gluconeogenesis. That's only glycerol can be used in gluconeogenesis. The other molecules, those other fatty acids are not going to be converted to produce glucose. Is it clear? So to produce glucose, to do gluconeogenesis, the main substrate that is going to be used is glycerol, because it is only this glycerol that can be converted to produce oxaloacetate, which is a major substrate of gluconeogenesis to produce glucose. Is it clear? Those other fatty acids are going to enter now in the cycle of to produce acetyl-CoA, such that they are going to enter the Krebs cycle to produce ATP. Is it clear? Now this is insulin synthesis and secretion, insulin synthesis, secretion, and metabolic action in the body. Is it clear? So now we need to know that what this at this level we have the pancreatic beta cells. Now you need to know that when glucose is bound to the glucose receptors, you have the glucose 2 transporter receptor. Is it clear? So is the glucose 2 transporter is going to convert that glucose that is bound to a glucose 6-phosphate. Is it clear? And then the glucose 6-phosphate is going to enter in metabolism such that it's going to increase the ATP level. Is it clear? Now ATP level is now, an increase in ATP now is going to cause now the activation of the channel. That is going to do what? Is going to cause an efflux of the potassium. So it's going to activate the sodium ion potassium ion ATPase channel. That's the potassium ion ATPase channel. That is going to cause now an efflux of potassium. Is it clear? So now when there is efflux of potassium, this one is now going to cause the stimulation. Immediately there is efflux of potassium, is now causing the stimulation now of the beta cell. So how does it stimulate the beta cell with efflux of potassium? So when potassium gets out, it makes now that the calcium can enter, because when potassium gets out, you are going to have a more negative potential inside the cell. So calcium can be attracted inside the cell. When calcium is attracted inside the cell, it's going to bind with vesicles containing insulin inside the cell. Is it clear? And now the vesicles now plus the calcium ion are going to bound to the wall for the release of insulin. So that is the general mechanism for insulin secretion. So all this is going to be summarized in this diagram. So in this diagram, we have already said everything involved. Start with glucose bounding to the glucose 2 transporter that's going to be converted to glucose 6-phosphate, which is going to be metabolized to produce ATP. Now ATP now is going to activate the potassium ATP channel. That's going to cause efflux of potassium. So calcium can enter because there's efflux of potassium, and now you are going to have the insulin. Calcium is going to bind to the insulin vesicles to release insulin. So generally that's that. Now the next thing is the metabolic action of insulin. So how does insulin act? So you need to know that insulin is going to promote the glucose uptake. Insulin is going to promote glycolysis. Insulin is going to increase glycogen synthesis, and insulin is also going to increase triglyceride synthesis. So generally this is a diagram where insulin is going to act. So insulin is going to increase the fructose 2,6 biphosphate. Is it clear? Now fructose 2,6 biphosphate now is capable of being converted, is interconvertible by the fructose 1,6 biphosphatidase. So you have this fructose 1,6 biphosphatidase is the main site where insulin is going to stimulate. It's going to stimulate the fructose 2,6 biphosphatidase. Is it clear? Now fructose 2,6 biphosphatidase is going to inhibit the fructose 1,6 biphosphatase and is going to stimulate the conversion of fructose 6-phosphate to fructose 1,6 biphosphate. Is it clear? So you need to know that these are the two major molecules in glycolysis. Is it clear? So when you have fructose 6-phosphate, it is the primordial molecule for gluconeogenesis. But when you have fructose 1,6 biphosphate, it's a primordial molecule for glycolysis. Is it clear? Now the fructose 2,6 biphosphatase is stimulated by insulin, and this fructose 2,6 biphosphatase enzyme is going to stimulate the conversion of fructose 6-phosphate to fructose 1,6-phosphate, and this fructose 1,6-phosphate is now going to result to normally the insulin. So is going to promote the fructose 1,6 biphosphate such that the glucose should be broken down in glycolysis. Is it clear? Also, now this fructose 2,6 biphosphatase is going to inhibit the action of fructose 1,6 biphosphatase, which convert the fructose 1,6 to fructose 6-phosphate. So it's preventing indirectly gluconeogenesis. So it's preventing insulin is going to act in such a way to prevent gluconeogenesis from occurring, and is going to promote glycolysis to occur. Is it clear? So by those actions. So this is to promote glycolysis. Now it's also going to promote glucose uptake. How does it promote glucose uptake? It's going to cause the glucose transporting channel, which is the glucose 4. Is it clear? To move from the cytosol to the cell membrane. So it causes more production of the glucose 4 from the cell, and the movement from cytosol to cell membrane. That's going to facilitate the transport of glucose. The next thing is that it's also going to increase glycogen synthesis. To increase glycogen synthesis at the level of the liver. So at the level of the liver is also going to cause the increase in production of glycogen. It's also going to cause increase in triglyceride synthesis, because acetyl-CoA carboxylase catalyzes the formation of malonyl-CoA. So you need to know that there are going to be more production of acetyl-CoA that can enter now to the production of triglyceride. Is it clear? So this diagram is just the insulin regulation of fatty acid synthesis. So what happens is that normally you need to know that glucose in glycolysis is converted to pyruvate. So insulin, we have already seen this step, how insulin is going to promote glycolysis, such that it's going to be converted to pyruvate. So now the pyruvate now can be converted by pyruvate dehydrogenase, so acetyl-CoA, so that it can enter the Krebs cycle. So in this way, it will enter the Krebs cycle and reduce glucose in blood. And also, the acetyl-CoA can enter another cycle of fatty acid synthesis, which is also directly stimulated by insulin. Is it clear? So enter a cycle of fatty acid synthesis, and in the fatty acid synthesis, one of the major conversion from acetyl-CoA is going to be producing malonyl-CoA. Is it clear? And malonyl-CoA is going to produce now the CPT1, which is going to be transported now. So you are going to have fatty acid transport into the mitochondria. Is it clear? Now those are the different things to visualize here. So those are how insulin is going to act in the different part of the body. Now the next one is ketone bodies. Now need to know that what the compound is going to be categorized as ketone. The major compound which are categorized as ketone bodies, we have acetoacetic acid, we have beta hydroxybutyric acid, and we have acetone. Is it clear? Acetone is formed spontaneously from acetoacetate and cannot be further metabolized. So immediately you have acetone in the body, it's not going to be further metabolized and it's produced from acetoacetate. Is it clear? So those are the three major ketone bodies which are present in the body. Is it clear? So ketones are formed from the liver in the liver mitochondrion. So you need to know that the ketones are formed only in the liver mitochondrion during fasting state when the insulin levels are low. Is it clear? So when you are fasting, you need to know that what in cases of fasting, you have very low glucose level because you are not eating. You are going to have very low glucose level. Since you have very low glucose level, insulin is not going to be stimulated because what the major stimulus for insulin is high glucose level. Is it clear? So when you have low glucose level, insulin is not going to be stimulated. Now you need to know that what insulin is an inhibitory factor for the production of ketone bodies. So when there is no insulin, ketone bodies are going to be produced. So if you fast, you start to, having sensation of fruity smell inside your nostril just because the ketone bodies are being produced. So they are going to be derived from the beta oxidation of the free fatty acid. So because the more you don't have insulin, the more you have now oxidation of fatty acid. So when you have beta oxidation of the free fatty acid, it's just going to result to ketone bodies formation. Now the question that you want to ask me is why the word beta oxidation? Beta oxidation is because it is the oxidation of the second carbon atom attached to the primary carbon atom. Is it clear? When we say alpha oxidation means that it is the oxidation of the carbon atom which has the functional group. In case of fatty acid, the carbon atom which have the functional group is the carbon atom which is attached to the COOH functional group. Is it clear? So that one is the beta oxidation. That one is alpha oxidation. So alpha oxidation is much more going to produce two carbon atom molecules such as acetyl-CoA. That's alpha oxidation. So when you do alpha oxidation, you produce acetyl-CoA that is going to be involved in the production of energy. That's going to enter the Krebs cycle and then later on enter the electron transport chain for the production of energy. Now, when you do now beta oxidation, you are now going to act on the carbon atom which is bounded to the carbon atom which is bounded to the functional group. So it's on the third carbon atom. That is why the molecule that are produced here is acetoacetate. Is it clear? Or hydroxybutyric acid. So this carbon atom, they have 3 carbon atom or 4 carbon atom in order for them to produce the ketone functional group. Is it clear? So they are going to be water soluble compound and do not need special carrier proteins because they are lipophilic. Is it clear? So you need to know that peripheral tissues like the heart, the muscles can convert the ketone bodies to produce the acetyl-CoA. Is it clear? So this is also going to be produced as a method of transport of energy in the body. So it can be used as a substitute of glucose when you are starving. Is it clear? So can be enter the Krebs cycle, which can enter the Krebs cycle and give energy. Now normally you need to know that what insulin block ketogenesis in 2 mechanisms. The first mechanism is by the fact that what is going to inhibit fatty acid release from the adipocyte. You need to know that what insulin inhibits fatty acid release from adipocyte. So if it inhibits the fatty acid release from adipocyte, there is no fatty acid that is going to be mobilized to the liver for the conversion to produce ketone bodies. And now the second method is that it's going to block the entry of fatty acid into the liver mitochondrion, which is going to boost the level of melanoline-CoA. Need to know that. So in this first step that we have seen, we have melanoline-CoA, and melanoline-CoA, it is only going to be converted. You have fatty acid transport into the mitochondria. When fatty acid is going to be transported in the mitochondria, you have the conversion to ketone bodies. Is it clear? But if the fatty acids are not transported to the mitochondria, there is no conversion to the ketone bodies. Is it clear? So it is just going to boost the entry of the fatty acid into the, it's going to boost the block the entry of the fatty acid into the liver, which is going to boost the level of the melanocortin. That's going to prevent the liver from oxidizing fatty acid. So beta oxidation, alpha oxidation are going to reduce when you have high level of insulin. Is it clear? Now, because this oxidation needs to occur at the level of the mitochondria of the kidney, beta oxidation, alpha oxidation occur at the level of the mitochondria of the kidney for the production of both energy and then also the production of ketone bodies. So we are finished with the ketone bodies. The next thing you're going to visualize is glucose-like insulinotropic peptides. Glucagon-like insulinotropic peptides. Now, oral administration of glucose is going to result in a bigger insulin response than an equivalent dose administered intravenously. Is it clear? So, when you administer insulin orally, is it clear? The response, when you administer when you administer glucose orally, there is a bigger insulin response as compared to when administered intravenously. Is it clear? So the best way of treating hypoglycemia is not by giving the patient oral, but instead intravenously, because of the response of insulin. So this has been attributed to the glucagon-like insulinotropic peptide. That's the glucagon-like insulinotropic peptide, a hormone that is going to be released into the bloodstream from the duodenum in response to dietary carbohydrate ingestion. Is it clear? So this glucagon-like insulinotropic peptide, actually they are going to stimulate insulin secretion. They are going to be stimulated. They are going to be released at the level of the duodenum when there is carbohydrate food. Is it clear? That's going to stimulate high insulin secretion as compared to when you are placing the insulin intravenously. The next is glucose transport. Now we need to know that the transport of the glucose into the cell, we have different transporters of the glucose into the cell. We have glucose transporter 1, which is wide distribution. This is found on the erythrocyte, on the fetal tissue, in the brain and the kidney. You need to know that insulin acts on glucose 4, which is found on the skeletal muscle, cardiac muscle, and adipose tissue. So this is where insulin is going to cause the glucose to enter the cell. But glucose 1 is on wide distribution. Glucose 2 is found on the liver and the pancreatic beta cells. Is it clear? For the release of the insulin. Glucose 3 is wide distribution also, and also especially in neurons, placenta, in the brain. Glucose 4 we have already seen. Glucose 5 is in small intestine. Transport fructose, not glucose. In glucose transporter 5, it only transport fructose but not glucose. Glucose transporter 6 is going to be a pseudogene not expressed at all protein level, and glucose transporter 7 is a microsomal diffusion of glucose out of the endoplasmic reticulum of the gluconeogenic tissue. Now, how do you prevent hypoglycemia? Now, you need to know that what tissue like brain and erythrocyte have obligate glucose requirement and constantly consume glucose. Is it clear? Now, you need to know that what, so in absence of glucose intake, the blood glucose level must be maintained endogenously normal. Is it clear? So glucose entry into the muscle adipocyte is reduced due to lack of functioning of glucose transporter 4. So actually these are the different steps that can make sure that the circulatory glucose should always be normal. So how do you prevent circulatory glucose to be normal? The first step is that there is the glucose transporter 4 is going to be the function is going to reduce. Is it clear? So the function of glucose transporter 4 is going to reduce such that the muscle and adipocyte are going to receive less glucose. Is it clear? So this denies the muscle access to glucose and spare the other tissue, that are non-insulin dependent glucose transporters. The non-insulin dependent glucose transporter are glucose transporter 1 and glucose transporter 3, which are widespread as we have seen here. So all the different parts of the body use glucose transporter 1 and glucose transporter 3. They are not dependent to insulin. Is it clear? All the different parts of the body except that of the muscles and the adipocytes. So the muscles and adipocytes are the ones that are dependent on insulin for them to have glucose. Is it clear? So that's why a patient who is diabetic is going to suffer from, and he does not have insulin which is being secreted, is going to suffer from muscle weakness and is also going to suffer from weight loss. Is it clear? But the other part of the body are still functional. Other cells of the body are still functional. Now, the next thing is that the lack of function of the glucose transporter 4 in adipocytes is going to result to insufficient alpha glycerol phosphate for re-esterification of fatty acid. Is it clear? So you don't have enough glucose for alpha glycerol, because the glucose is the one that is going to produce the alpha glycerol phosphate that is going to be used for esterification reaction for the production of triglycerides from fatty acid and glycerol. Is it clear? So when you want to esterify fatty acid and glycerol to produce triglycerides, is it clear? There is not going to be that glucose that's going to produce the alpha glycerol. Is it clear? So the free fatty acid is going to be left at the level of the adipocyte, also going to travel. See, since the fatty acid now is free and not stored, the fatty acid is going to be traveling at the level of the liver. In the liver, low insulin now causes the level of the malonyl CoA to fall. Is it clear? So at the level of the liver, malonyl CoA is going to fall, which is going to leave the inhibition of the CPT1 and allow the fatty acid to be transported into the hepatic mitochondria and then oxidize to produce ketone bodies. Is it clear? You just remember this our diagram that we've just seen above here. We said that if you have insulin is going to synthesize more of the malonyl CoA, and malonyl CoA is going to inhibit this enzyme here, which is CPT1, and CPT1 is involved in the transport of fatty acid into the mitochondria. So when there is inhibition, there is malonyl CoA production and inhibition of CPT1. There is reduction in transport of fatty acid into mitochondria, so there is no alpha and beta oxidation. No ketone bodies is going to be produced. Is it clear? Now, if it's now reduced, like in a case where you have low insulin in the body, is it clear? So when you have lack of insulin, you are going to have that low malonyl CoA. So ketone bodies, ketogenesis is going to occur. The next is lack of insulin is also going to cause the liver to switch from glucose consuming to glucose producing organ. Is it clear? So the first is through glycogenolysis. That's the first method of production of gluconeogenesis, glycogenolysis. Is it clear? So the first method is glycogenolysis to produce glucose. Then once the glycogen is depleted, there is going to be glycogenic amino acids like alanine is going to produce glucose. So other methods are going to produce. So hepatic gluconeogenesis also going to stimulated by the depression of the fructose 1,6 phosphatase. Is it clear? So these are all the methods such that glycogenolysis is produced, is going to be activated, and gluconeogenesis is activated. So we are finished with how to prevent hypoglycemia. So all those are the methods. The next is the counter-regulatory hormones of insulin. So the first counter-regulatory hormone of insulin is going to be glucagon. Glucagon is a 29 amino acid polypeptide that is going to be secreted by inside the alpha cells of the pancreatic islets of Langerhans. Is it clear? So now we need to know that this is the first hormone that is going to be released if glucose level now fall. Is it clear? So the first case is in the counteraction of hypoglycemia, we have low level of insulin. Also, if there is low level of insulin, the next hormone that can be secreted is glucagon. Now that glucagon is also going to act at the liver for both glycogenolysis and gluconeogenesis. Now we have regulation of secretion. Is it clear? So how is the secretion of glucagon regulated? You need to know that the alpha cell is responsive to a number of signals that are potential from hypoglycemia. So if you have low blood glucose, it's going to cause the primary stimulus, which is the primary stimulus of glucagon. Is it clear? Mostly at the night. Is it clear? So glucagon is going to be elevated to prevent hypoglycemia. The next is protein derived amino acid, also going to stimulate insulin and glucagon production. Is it clear? So if you have protein derived amino acids, you are going to have both stimulation of insulin and glucagon, protein derived amino acid. Is it clear? So that's why if you eat for diet which is high in proteins, is it clear, and less in carbohydrate, you feel as if you are not at satiety. Is it clear? You feel as if you are not at satiety because the glucose level is not going to neither increase nor decrease, because both the insulin and glucagon are secreted at the same time. Is it clear? So it's good to eat a diet which is both containing carbohydrate and protein, not only proteins, because insulin and glucagon are going to be secreted at the same time. Now, the glucagon is going to effectively antagonize the insulin and prevent hypoglycemia. Is it clear? That would otherwise result from insulin secretory response. Now, the next is adrenaline. So sorry, I just made an error with the first explanation. Satiety is going to occur more when you eat protein-derived food. Is it clear? When you eat protein-derived food, you have both insulin and glucagon that is going to be produced. Imagine that you eat only carbohydrate-derived food. When you eat carbohydrate-derived food, what happens is that there's going to be high insulin secreted. So when high insulin is secreted, the glucose in blood is going to be low, and continuously low. So if you eat a food that is fastly secreting carbohydrate, you are going to always have low glucose level because of high insulin. Is it clear? So the brain is not going to find so at the level of the hypothalamus, you are not going to be at satiety, because the brain is not going to analyze the fact that there is high glucose level. So when you eat both a protein derived food, you have both insulin and glucagon that are secreted. So by that time, you also have high glucose level that is going to inhibit that. Is it clear? So in a protein meal, both insulin and glucagon are secreted. Now the next is adrenaline. Now you also need to know that what adrenaline can also act as a regulatory mechanism for the stimulation of the alpha cells. Is it clear? So adrenaline from the adrenal medulla and the noradrenaline produced from sympathetic innervation at the level of the pancreas can also stimulate the glucagon, such that glucagon can increase glucose level. Is it clear? So that's the way by which adrenaline can increase glucose level. The next is adrenaline. So adrenaline is the next hormone that we are going to speak in order to increase glucose level. So those are the methods. The first method by which adrenaline changes the glucose level, glucose metabolism, is that a tyrosine derived. So adrenaline is actually a tyrosine derived molecule. A tyrosine is an amino acid and is derived from the adrenal medulla, and that counteracts hypoglycemia. So what are the methods by which adrenaline counteract hypoglycemia? It's going to activate glycogenolysis at the level of the muscles and the liver. It's going to stimulate their adipocyte lipolysis via hormone sensitive lipase, so activate the lipase enzyme, and then it's going to directly inhibit insulin release, adrenaline. So this ensures that what you have blood glucose remain high in cases of emergency increase in energy demand. Is it clear? And also you need to know that adrenaline is released adrenaline release triggered by lower blood glucose level than that occur in the normal fasting state. Is it clear? So when you have extreme low glucose level, you have stimulation of adrenaline. The clinical features of hypoglycemia are mainly attributable to adrenaline. Is it clear? So if you have hypoglycemia. Clinical features of hypoglycemia are mostly due to adrenaline. You need to know that what hypoglycemia, which is associated with what agitation, which is associated with sweating and all that, is because of secretion of adrenaline. Because one of the major causes of adrenaline secretion is going to be hypoglycemia. We can have fear and all those characteristics. You can have fear, fright, and all that, but the major cause of adrenaline secretion is hypoglycemia. Is it clear? So when there is hypoglycemia, adrenaline is going to be secreted. Like those features that's going to result to features of agitation, sweating, palpitation in hypoglycemia. Now, tumors of adrenal medulla, known as pheochromocytoma, is going to secrete excessive adrenaline, is it clear, and no adrenaline, which is going to lead to hyperglycemia. So that's why patients with pheochromocytoma are instead going to have hyperglycemia. Now, the next hormone that is also involved with glucose metabolism is cortisol. A steroid is going to be released from the adrenal cortex in response to adrenocorticotropic hormone, and it's going to promote protein catabolism. Is it clear? The main role of steroid is just to promote protein catabolism, and that protein catabolism is going to result to gluconeogenesis by activating the gluconeogenic enzymes in the liver. Is it clear? So it ensures that the alanine delivered to the liver is converted to glucose. So cortisol is going to convert glucose. So cortisol is going to convert to the production of glucose from other sources, and mostly from protein. So it's the conversion from protein to do gluconeogenesis. So every time patients with Cushing's syndrome having increased cortisol level are going to have hyperglycemia. That's why Cushing's syndrome is a risk factor for you to have diabetes mellitus. Now, growth hormone. How does growth hormone affect glucose level? You need to know that one, a peptide hormone is going to reach the secreted at the level of the anterior pituitary gland. Is it clear? It's going to promote lipolysis, is one of the major factors. It's going to promote lipolysis, that's hydrolysis of triglyceride, to produce free fatty acid and glycerol. Is it clear? So that's one major part. So it promotes lipolysis. So in growth hormone, it's going to promote actually growth. So what it's going to do is that there is first lipolysis, that is, and that's the destruction of the lipids, so as to produce fatty acid and the glycerol. Is it clear? In adipose tissue, which is going to provide now the fuel to glucose. Is it clear? In patients with chronic starvation, growth hormone limits now muscle production breakdown by promoting the use of the fatty acid derived from fat stores as the energy alternative. Normally, growth hormone is involved in the breaking down. The end phase of growth hormone is to produce normally proteins. Is it clear? So that's the main role of growth hormone, and it's going to produce proteins by converting fatty acids to first glucose, and then converting glucose now to produce the amino acid that are going to produce the proteins. Is it clear? So that's why the growth hormone is going to do lipolysis. Now also, growth hormone is going to activate the production of insulin-like factors. Is it clear? Insulin-like peptides. It's going to stimulate insulin-like growth factor 1 and growth factor 2 at the level of the liver. Is it clear? And when there is stimulation of insulin-like growth factors 1 and growth factor 2, they just act like insulin to promote the glucose entry into the cells, and that glucose that is entered into the cell can be converted now to produce proteins that are going to be helping in the build-up of the human body. So fasting, we need to know that fasting is going to stimulate growth hormone. Is it clear? Unlike insulin, so fasting is going to stimulate growth hormone, and glucose administration also lowers growth hormone. Is it clear? So that is the thing that you can know in this patient. So fasting is going to stimulate growth hormone. So when you are fasting, you are going to stimulate growth hormone to increase the glucose level. When you fast, the lipolysis is going to increase so that glucose can increase, and then the protein can be produced. Why when there is administration of glucose, there is no need for growth hormone to be stimulated. There is no need for lipolysis to occur. Now, the other hormones that are involved with the glucose cycle is going to be somatostatin, that is from the delta, that's produced from delta cell of the pancreatic islet. Is it clear? And then it's not directly involved with the metabolism. It inhibits the growth hormone release, and it promotes and also inhibit the release of insulin and glucagon. That's the role of somatostatin. It is, you need to know that somatostatin is one of the hormones which is mostly used in inhibition. Is it clear? Inhibition is somatostatin. Inhibition of growth hormone release, inhibition of insulin, inhibition of glucagon. Now the next is tyrosine. So tyrosine from the thyroid gland is and also not directly involved with the stimulation of glucose, the glycogenolysis, but it's also involved in that. Now the next thing that we are going to speak about is going to be diabetes mellitus, which is a disease. Now, diabetes mellitus is a state of chronic hyperglycemia where you have excess glucose level, which is caused by a defect in insulin secretion. Either it's a defect in insulin secretion, where it's the insulin dependent diabetes mellitus, or you have a defect in action, or you have even both. Is it clear? The result is going to be a metabolic disturbance. So you can visualize the issue of diabetes here. I'm not going to speak about that. And now we directly go to the causes of hyperglycemia. So what can cause you to have high level of glucose? A major cause is diabetes mellitus. Now other causes, we had other hormones that were increasing the blood glucose level. One of the hormones were the adrenaline and noradrenaline. In cases where you have pheochromocytoma, you're going to have hyperglycemia. Another hormone that increased glucose level was cortisol. In that case, you're going to have Cushing's syndrome. Another hormone that increased glucose level was growth hormone. In that case, you're going to have acromegaly. Another hormone that does glycogenolysis is thyroid hormone. In that case, you can have thyroid toxicosis. So you can see the different hormones and the different cause of hyperglycemia. Now, the stress related, so you can have also stress. In case of stress, which is associated with the release of cortisol, you can have growth hormone, which is you can have cortisol, which is secreted that stimulates glucose production. Now, stress-related effects such as infections, trauma, cerebrovascular accident, all of that can cause hyperglycemia. The next, pancreas. In the pancreas, you need to know that one. If you have glucagonomas, that's tumors of the alpha cells, and you have pancreatitis, you can also have hyperglycemia. You can have drugs like steroids, and you have thiazide, which is also involved with that. Now, secondary causes of diabetes are rare, but are important to exclude. Usually, the secondary causes of diabetes are rare. Is it clear? I know that it's in less than 20%. Usually, diabetes is a primary cause. It's not coming from another thing. Is it clear? But the secondary causes are rare. Now, the next one is diabetes is generally divided into two types. You have type 1 diabetes and you have type 2 diabetes. The prevalence of type 1 diabetes that is less common, 5 to 10% of all cases. Now, why type 2 diabetes is very common in adults, and it is 90% of all cases is type 2 diabetes. The age of onset of type 1 diabetes is juvenile, while the age of onset of type 2 diabetes is maturity, that's greater than 40 years. Presentation, you have acute symptoms are usually presented, and the acute symptoms here are hypoglycemia and a hyperglycemic crisis. And usually the hyperglycemic crisis associated with type 1 diabetes is diabetic ketoacidosis. Now, usually the symptom presentation here is gradual. Is it clear? Though it can present with an acute state. Is it clear? So you can present an acute state of hypoglycemia. You can present with hyperglycemic, hyperosmolar non-ketotic state, and also present with diabetic ketoacidosis, provided that it has converted to an insulin dependent diabetes mellitus. Now, insulin here is absolute lack. There is a relative absolute lack. At the beginning of type 2 diabetes, you have insulin resistance, but at the end of the type 2 diabetes, where there is no secretion of insulin, there is insulin lack. For the physique, you have usually there is lean body mass here, and usually they are obese. It is their central obesity which resulted to their type 2 diabetes, because that's the adipokines which are secreted by the adipocytes are those factors that cause insulin resistance. Now, at the level of the islets, you have inflamed or destroyed. Is it clear? The islet is inflamed or destroyed here. The islet may be near normal appearance. Ketosis, typically there's diabetic ketoacidosis here. Typically there's a hyperosmolar non-ketotic state. Now, here you need to know that the etiologies, there are different etiologies of type 1 diabetes as compared to type 2 diabetes, which is more genetic. Is it clear? The etiology of type 1 diabetes is that you can have an autoimmune disease. Is it clear? One. The second is that you have antibodies that can be detected in the serum before the onset of diabetes. You see the antibodies, anti-beta cells. Is it clear? Anti-beta cells can be detected in the serum. You can have also HLA association, viral association. Is it clear? So when you have, it can be HLA associated. Is it clear? So viruses that can affect the HLA genes of the body can cause that, like Coxsackie virus. Now, here in type 2 diabetes, it has a very strong genetic component, and it's going to be aggravated by obesity. Is it clear? So that's why usually the genetic component is shared with what is called metabolic syndrome or syndrome X. Is it clear? And that syndrome X is shared with 5 things. The first is hyperglycemia, the second is central obesity, the third is hypertension, the fourth is hyperuricemia, and the fifth is hypercholesterolemia. Those are the 5 components of the metabolic syndrome or syndrome X. Now, the gene defect of the beta cell secretory, you have gene defect of beta cell secretory apparatus, and then the third gene link, low birth weight. It can also be associated with patients who have low birth weight. Is it clear? Now, the next thing that we are going to speak is syndrome X, what I was just speaking about before, or metabolic syndrome. So this is a cluster of risk factors of heart disease associated with insulin resistance, and which was described by Gerard Raven. Is it clear? So what are the factors in syndrome X? The first thing is that you have a central obesity with a BMI of greater than 28. Is it clear? You can have a BMI of greater than 28 kilogram per meter squared, or better still, you could just measure the waist circumference. If the waist circumference is greater than, if the ideal waist circumference, that it should be less than 94 centimeters, but if it is greater than 102, is bad. Is it clear? And then for the case of the woman, if the waist circumference is greater than 88 centimeters, it's bad. Is it clear? It's high risk of central obesity. Is it clear? So you measure in both males and female. The next, in syndrome X, you have hypertension. The waist circumference is measured. When you may want to measure the waist circumference, you measure at the level of the iliac crest. Just we measure above the iliac crest, you're going to have the waist circumference. While the abdominal circumference, to measure the abdominal circumference, you measure from the umbilical straight around the abdomen. Is it clear? So the second element of syndrome X or metabolic syndrome is hypertension. The third is dyslipidemia, which is characterized by hyperlipidemia with small, dense, low density lipoproteins. You have low density lipoproteins, and you have you have high number of low density lipoproteins, and you have low number of high density lipoproteins in this form of dyslipidemia. You have insulin resistance, where you can have a hyperglycemia, you can have type 2 diabetes. This is often associated with type 2 diabetes. Is it clear? So when normal amount of insulin fails to maintain the glucose level, so in this patient, you have normal insulin that is secreted, but you have hyperglycemia. You have high fibrogen level is another one that has been added. High fibrogen level is also implicated sometimes in metabolic syndrome, and you also have hyperuricemia. Now the thrifty gene. The thrifty gene was once important for survival. It is thought that to regulate the hormonal fluctuation to accommodate the seasonal changes. Is it clear? This facilitates storage of fat when food is available and its utilization when food is scarce. Low birth weight baby can grow to be obese when food is available. Is it clear? So you need to know that what this SchrDbb gene is a gene which is affected, which is associated in other disorder of diabetes mellitus, because this gene is an important gene for survival. Is it clear? And it is thought to regulate the hormonal fluctuation to accommodate seasonal changes. So you have a child who has low birth weight, and that is having a high risk factor to have essential obesity in future time, like Native Americans, where that SchrDbb gene is associated with it. Now, what are other variants of diabetes? We have type 1 diabetes, we have type 2 diabetes. Other variants of diabetes, we have maturity onset type diabetes of the young. Is it clear? So MODY. So this MODY is a type 2 diabetes. Actually, it's a type 2 diabetes that's developed typically as type 1 age group. Is it clear? So MODY is maturity onset, so a mature type of diabetes in youngs. Is it clear? So maturity onset diabetes of the young. So this is a type 2 diabetes that occur in type 1 diabetes age group. Is it clear? So 4 genetic defects have been identified and associated to this. Now, the next form of diabetes now is a gestational diabetes, which is during pregnancy. So here you have a pancreatic function might not be sufficient to overcome both the insulin resistance and the anti-insulin hormone that is secreted by the placenta. You have hormones like anti-insulin hormones. The first thing is that the cells of the child require to have more insulin. Is it clear? And then there is also insulin resistance, because the placenta produces certain hormones like estrogen, prolactin, human placental lactogen, cortisol, and progesterone, which are anti-insulin. Is it clear? So they are going to try to inhibit to resist insulin. Is it clear? So you see that gestational diabetes resemble more of type 2 diabetes than type 1 diabetes. Is it clear? Now, diabetic patients who become pregnant do not have gestational diabetes. Is it clear? But they have diabetes mellitus and pregnancy. So we don't talk about gestational diabetes in a diabetic patient that has become pregnant. It's actually a normal patient who is having a hyperglycemic state in pregnancy. That's called gestational diabetes. Now, what are the risk factors for you to have that gestational diabetes? You have family history of diabetes in the first degree relative. You have obesity. You have advanced maternal age. You have previous advanced pregnancy, and you have screening recommended of diabetes, of this gestational diabetes as approximately at 28 weeks. So at 26 weeks, that's from 24 to 28 weeks. Is it clear? So how do you screen? You do the fasting blood glucose can be one method of screening. Fasting blood glucose. The next, where the fasting blood glucose has to be less than 126 milligram per deciliter. You can do random blood glucose, which has to be less than 200. And now also you need to do the oral glucose challenge test. Is it clear? So in oral glucose challenge test, what you do is that you have 50 milligram of glucose that is given orally, regardless of the time of the last meal. Is it clear? And then glucose is measured 1 hour after. So this is the best data that is used in order to diagnose gestational diabetes. Is oral glucose challenge test. Is 50 grams of glucose is given regardless of the time that you have eaten meal, and then you measure glucose 1 hour after. The patient with a greater than 7.7 millimole per liter of glucose is said to have a positive oral glucose challenge test, or a patient that has greater than 140 milligram per deciliter of glucose is said to have a positive oral glucose challenge test. Is it clear? So what is the diagnosis of diabetes? So these are the different methods to diagnose diabetes. You can use the American Diabetes Association classification to diagnose diabetes. Is it clear? So diagnose diabetes, you have you have symptoms of diabetes. First start with the symptoms of diabetes. The patient should have symptoms of diabetes plus a random plasma concentration of glucose of 11.1 millimoles per liter or greater than 120 milligram per deciliter. Is it clear? So that is the first. You have symptoms of diabetes plus you have random blood glucose level of greater than 120 or greater than 200 milligram per deciliter. That's one way to diagnose diabetes mellitus. The next way to diagnose diabetes mellitus is a fasting blood glucose level of greater than 7 millimoles per liter or greater than 126 milligram per deciliter. Is it clear? So fasting defined as no caloric intake for at least 8 hours. So here you take the glucose level in the early morning. Is it clear? So if you have a fasting blood glucose level is taken when you have no caloric intake for at least 8 hours. So you can drink water but no food. So 2 hours post-load glucose. You can have also a 2 hours post-load glucose, which is also during an oral glucose challenge glucose tolerance test. Is it clear? So in oral glucose tolerance test, you can do a 2 hour post-load glucose of after you have given 50 so the test should be performed as described by WHO, where the glucose load of containing, in the case where you want to do in a normal patient, in the case where you do in a pregnant woman, you use 50 grams of glucose and then you do 1 hour later after the meal to find if it's going to be greater than 140. Now for the oral glucose tolerance test, in the case of a patient that is normal, you use 75 grams of glucose. Is it clear? So you use 75 grams of glucose in water and then you measure 2 hours later. If it is greater than 11.1, that is greater than 200 milligram per deciliter, is another method to diagnose. Is it clear? 2 hours later you use 75 grams. 2 hours later it should be, if it's greater than 200 milligram per deciliter, then it's very bad. So in absence of unequivocal hyperglycemia, this criteria should be confirmed by repeat testing at different days. Now this is the oral glucose tolerance test protocol. So the patient should have a normal mixed diet for previous 3 days prior to the test. Now the patient is fasted overnight. So when you fast him overnight, so for glucose measurement before 75 grams is given. So in this oral glucose tolerance test, you first fast the patient overnight. Is it clear? Now when you fast the patient overnight, you give him 75 grams of glucose that is going to be administered orally in 200 ml of water. 75 grams of glucose in 200 ml of water. Is it clear? Now the blood glucose is going to be measured every 30 minutes for 2 hours. You measure the blood glucose every 30 minutes for 2 hours. The subject should rest during the test and should not smoke nor eat. So the glucose is drawn into sodium fluoride tubes. Sodium fluoride is the enzyme inhibitor that prevents the glucose from being metabolized by cell. Is it clear? So when you take the glucose, when you take the glucose, you take the blood of the patient every 30 minutes for 2 hours, you are going to take that blood in sodium fluoride. So that sodium fluoride is going to inhibit the red blood cells and the white blood cells which are present in blood from metabolizing that glucose that is present in blood. So fluoride ion prevent glycolysis. That's so the first is that you have the sodium fluoride is going to inhibit the enzyme, and the fluoride ion is going to prevent glycolysis by binding magnesium that is going to be required for glycosylating events. Is it clear? Now in normal subject, the plasma glucose is going to rise and return to fasting level by 2 hours. Is it clear? So the in normal subject fasting, the plasma glucose is going to rise and then it's going to return to normal level by 2 hours. So the plasma glucose is going to be greater than 11 point, is going to confirm that of diabetes mellitus. So immediately your plasma glucose is greater than 200 milligram per deciliter. Is it clear? After 2 hours, at the time of 2 hours, it's going to confirm that you have diabetes mellitus. Now the oral glucose challenge test is also very important to diagnose another case states where it is called impaired glucose tolerance. Is it clear? So you can have also impaired glucose tolerance in case of patient. Is it clear? So if 2 hours after the value lies, so it 2 hours after the values lie between 126. If 2 hours after the value lie between 140 to 200 milligram per deciliter, that's 7.8 to 11.1 millimole, then the patient is said to be glucose intolerant. Is it clear? Now the next one, although not frankly diabetic, this patient should be followed up for later case of diabetes. Now the next is a case, so that's a case of oral glucose. So patients who are with fasting glucose between 5.6 to 7 millimoles are labeled impaired. So you can have also fasting blood glucose of 5.6 to 7. Is it clear? The fasting blood glucose should be less than 126 milligram per deciliter. If you are between 126 to 140, you are labeled as impaired fasting glucose level. Is it clear? So you need to know that there are two main cases. The first case is when you are fasting. So when you are fasting and your blood glucose level is between 126 to 140 milligram per deciliter, it is called impaired fasting glucose level. Is it clear? And now when you are having a patient where you are giving glucose and then the glucose is high, that is between 140 to 200 milligram after an oral glucose tolerance test, you call those patients impaired glucose tolerant. Is it clear? Impaired fasting glucose just means that what you are fasting but your glucose is high. It means that there is a high probability that your cells do not respond to glucose metabolism normally. While in the case of impaired glucose tolerant, in this case, you have eaten, but your glucose level is high. Normally, when you eat, your glucose level is dropping because insulin is secreted. So in impaired glucose tolerance, these people have low level of insulin than normal. But in impaired fasting glucose, these people have low level of glucagon than normal. But the patients who are impaired glucose, generally the patients who are impaired fasting glucose and impaired glucose tolerance are going to be analog. They are opposite. Is it clear? So patients who have impaired fasting glucose do not necessarily have diabetes mellitus. Is it clear? Patients with impaired fasting glucose not necessarily have diabetes mellitus. When they fast, they have a glucose level which is higher than normal. Is it clear? So it means that what? It means that the hormone which is supposed to break down to produce glucose, that's glucagon, is not well secreted in impaired fasting glucose level. While impaired glucose tolerant, you have glucose in your body, but you don't produce enough insulin. So the best way to diagnose diabetes mellitus and all the forms of insulin resistance and insulin on secretion is going to be by using an oral glucose challenge test or oral glucose tolerance test. This other method of fasting is mostly going to involve disorder of glucagon. Is it clear? So it's just used as an aside diagnosis. The best diagnosis is going to be oral glucose tolerance test. Now, what is modified oral glucose tolerance test? Now, in case of gestational diabetes, fasting, so it's at least 2 hours. Is it clear? So if you have fasting of 5.3 that or 1 hour later or greater than this of this, so if you have different values of these are different values of the oral glucose tolerance test with different hours involved that you can still work with. Now, another disease still involved in glucose metabolism is renal glycolia. So this is a benign condition in the patient with normal blood glucose level. Is it clear? So this patient have normal blood glucose level, but the kidney is secreting urine. Normally, you need to know that there's a threshold value for the kidney to start secreting urine. Is it clear? And that threshold value is when the glucose level is greater than 180 milligram per deciliter. So immediately you see glucose in urine, just know that there is a threshold value of greater than 180 milligram per deciliter of glucose in blood. Is it clear? But there are certain cases like renal glycolia where the kidney just secrete glucose without you having a high level of glucose in blood, normal level of glucose in blood. So this defect is a defect with a tubular threshold. Is it clear? For reabsorption. Normally, you are supposed to reabsorb all the glucose in blood, notwithstanding the fact that the threshold has to, be less than 180 milligram per deciliter. Now, in patients with renal glycolia, that threshold now is reduced. Is it clear? So the threshold can be reduced to 120. Immediately, the blood glucose is greater than 120 or even greater than 100. You are going to have renal glycolia. Now, what are the complications of diabetes? Complications of diabetes can be divided into acute and then chronic complication of diabetes. Now, for the acute complication of diabetes, you have diabetic ketoacidosis. Is the first acute complication of diabetes. So, for acute complication of diabetes, you have diabetic ketoacidosis. So in diabetic ketoacidosis, we start with the hallmark. The hallmark of diabetic ketoacidosis is going to be type 1 diabetes mellitus, and it's going to be characterized by hyperglycemia, hyperosmolarity, low pH, ketonuria, and ketonemia. As easy as that. You have diabetes, that's hyperglycemia. You have ketones in urine, that is ketonuria, and you have ketones in blood, ketonemia. You have acidosis to tell you that the pH is going to be low. So that's the typical characteristic of diabetic ketoacidosis. And since there is hyperglycemia, there's also going to be hyperosmolarity. So this is an acute emergency. It's going to be developing in a diabetic patient that have interrupted their insulin therapy. That's the first thing. So in patient that does not take their insulin, you have it because excessive ketones are going to be produced. It can be precipitated by physical stress like trauma or infections. You can have it. It can also present in previously undiagnosed diabetic patient like type 1 diabetic patient. The presentation that the patient is going to be distressed. You need to know that when you have hyperglycemia, you always come in a case of distress. Is it clear? So they are also dehydrated because most of the glucose has caused fluid to be lost in the urine, secondary to polyuria, nausea, vomiting, and present with hypotension, tachycardia, dry skin, and poor urinary output. Breathing is rapid and deep, that's Kussmaul, due to Kussmaul breathing. So all these characteristics is because of hyperglycemia. Hyperglycemia is going to cause agitation, it's going to cause all these symptoms. Is it clear? Now, you have now the symptoms of dehydration because of hyperglycemia. Is it clear? Now, because you also need to know that glucose is more in the extracellular fluid than intracellular fluid. So when there's the excess glucose in the body, it's going to cause the shift of fluid from intracellular to extracellular fluid and cause dehydration. And the dehydration is also going to result to a cell shrinkage. So the first part of the dehydration here is going to affect the urinary output. It's going to cause tachycardia and even hypotension before you have confusion and tachycardia. Is it clear? Now, the next, you have breathing is going to be rapid, it's going to be deep. Is it clear? In the case of Kussmaul breathing due to the acidosis. Is it clear? And then you have acetone breath. Those are the triad of the symptoms. Now, what is the biochemical derangement in ketoacidosis? The first biochemical derangement is hyperglycemia, where the hyperglycemia, the value is going to lie between 20 to 50 millimoles per liter, which is equivalent to 300 to 600 milligram per deciliter. Is it clear? Or 250 to 500 milligram per deciliter. That is the typical value of hyperglycemia in diabetic ketoacidosis. So you need to know that the liver is going to synthesize glucose from the muscle derived alanine and all that since the liver is going to synthesize, since there is no insulin, glycogenesis is going to occur, and then it's going to lead to higher urea level. Is it clear? Which is going to couple now the hypovolemia. Now the next one is, despite the loss of glucose in urine and cessation of food intake due to drowsiness and vomiting, glucose level continues to increase. Is it clear? Once the polyuric patient become oliguric. Now the next is metabolic acidosis. Now metabolic acidosis now occur in, so here in metabolic acidosis is the next characteristic of ketonuria. Now metabolic acidosis occur because the acetoacetate, the beta hydroxybutyrate, are acid elements. Is it clear? They're going to produce acidic component. Is it clear? That's why the pH is going to be less than 7.35, which is the normal pH of blood. Is it clear? So usually the pH in this case of metabolic acidosis is going to range between 7.0 to 7.2. Now you need to know that in this case you're going to have a metabolic acidosis with a high anion gap. Why? Because the ketone molecules are going to act like the unmeasured anion in blood. Is it clear? Now in diabetes, the ketone bodies are lost in the urine with the retention of hydrogen ion. Is it clear? An elevation of ketone bodies concentration result in acidemia. So those are the different things. So hydrogen is going to also release from the acid buffered bicarbonate. You need to know that the method by which this is going to be counteracted is the fact that the hydrogen is going to bind with the hydrogen carbonate to produce carbon dioxide and water, and carbon dioxide and water is going to be released at the level of the lungs. Is it clear? The hydrogen is going to be released at the level of so hydrogen and the hydrogen carbon ion are going to bind at the level of the lungs to produce carbon dioxide and water, which is going to be released and cause Kussmaul breathing. So we continue with lactic acidosis. The next part of the tutorial is going to be on lactic acidosis. So patients often severely dehydrated associated with poor perfusion resulting in lactic acidosis. Is it clear? So all these are metabolic derangement in diabetic ketoacidosis. We have also lactic acidosis. Another metabolic derangement in diabetic ketoacidosis is sodium and water derangement. So for sodium and water derangement, we have significant water loss, which is due to the glucose induced. So we are going to have that's the next case. So the next one is sodium and water metabolic impairment. So in sodium and water metabolic impairment of diabetic ketoacidosis, you have significant water loss, which is due to glucose induced osmotic diuresis, which cause plasma sodium which is going to cause plasma sodium to rise. Is it clear? So if you have a significant loss of water of water from glucose, because glucose is going to be very high. Is it clear? Since glucose is very high in blood, you are going to have osmotic diuresis. So glucose is going to be lost with water, and that is going to cause an increase in sodium ion in the extracellular fluid. Is it clear? The increase in sodium ion in the extracellular fluid is going to cause now intracellular dehydration by pulling fluid from the intracellular fluid to the extracellular fluid. Is it clear? That's why in this case you are going to have that's the next thing. So this offset of hyperglycemia drawing water out of extracellular fluid is going to result to dilutional hyponatremia and loss of urinary sodium. Is it clear? So it's going to draw the water out of extracellular fluid and also some of the sodium ion. Is it clear? As it is pulled out. Now the first you need to know that it is possible to estimate the extent of dehydration from measured sodium and glucose. Is it clear? Now the first you need, so this is the formula in order to estimate the method of dehydration in the patient who have diabetes. Now the other metabolic derangement in diabetic ketoacidosis is potassium and other electrolytes. So potassium tends to leave the cell during ketoacidosis. Is it clear? During ketoacidosis, potassium tends to leave the cell. Now you need to know that intracellular potassium binding sites include the proteins. So during ketoacidosis, potassium is going to leave the cell because the potassium, the cells, the ketones which are present in the plasma is going to attract the potassium out of the cell. So you are going to have a form of hyperkalemia. Is it clear? So because of slightly elevated potassium ion level in blood. So both phosphate and magnesium are other intracellular ions that may also be lost because of the ketoacidosis. The ketones inside the blood plasma is also going to attract the magnesium ion and the phosphate ion. Is it clear? So you are also going to have their elevation in blood. Now during late glycolysis, inorganic phosphate are incorporated. During late glycolysis, you need to know that inorganic phosphate are going to be incorporated. This translates into sudden drop of phosphate in diabetic ketoacidosis. Now, the next also in diabetic ketoacidosis is abnormal renal function. So as the hydration worsens, you're going to see that the renal perfusion is going to deteriorate. So you're going to have elevation of the urea and creatinine from a low level of glomerular filtration rate. Is it clear? So the falsely elevated creatinine level can be caused by a high serum acetoacetate concentration. Acetoacetate interfere with the Jaffe's reaction that is mostly utilized in creatinine measurement. You can have a falsely elevated creatinine level. It may not be elevated in all cases because there is interference of the Jaffe's reaction which is used in creatinine measurement. Now, how do you treat diabetic ketoacidosis? To treat diabetic ketoacidosis, the mainstay of the treatment is going to be rehydration. Is the first thing that you do. You do insulin administration for hyperglycemia. You do the monitoring and replacement of intracellular ions, particularly that of potassium ion, because that's the most detrimental ion in the human body. And you have to look for and treat for predisposing causes of infections. You have to find for the cause of the disease. So those are the different things. You can also even treat the acidosis in this case here. So these are the different things. So to treat for the fluid, you have to give 6 liters of fluid in 24 hours. Generally, that is how you give fluids for a diabetic ketoacidosis patient. 6 liters of fluid in 24 hours. The next is it is important to realize that this high continuous doses of insulin may cause blood glucose level to normalize rapidly. However, insulin therapy should not be terminated until the patient has normal pH. Is it clear? And urinary ketone are undetectable. So you should not terminate insulin even if the patient has normal glucose level. You should not terminate insulin therapy unless the patient has acidosis. Unless the patient has acidosis, is it clear? And ketosis, you should not terminate the insulin. Is it clear? So you should not terminate to give insulin to the patient. So under these circumstances, dextrose containing IV fluid should be administered while you give insulin. Is it clear? So at the same time you give insulin and you give dextrose, still you continuously give them all these elements, because acidosis can still result to hyperkalemia, and you want to prevent the acidosis can result to hyperkalemia. I want to prevent the hyperkalemia by giving the continuously insulin to the patient, and to prevent the patient from having hypoglycemia, you place him on dextrose. Is it clear? You place the patient on dextrose and then you give the patient insulin such that the acidosis can make sure that the patient relieves from the hyperkalemia. Is it clear? Now, the next one is bicarbonate replacement. So that's another way to treat now the acidosis. To treat the acidosis now, you can also use bicarbonate replacement, but provided that you don't have bicarbonate with you, you can just use your dilution method and use any diuretic. Is it clear? But you can, the best way to treat the acidosis by giving a bicarbonate to the patient. Is it clear? You administer the bicarbonate, and you have to administer such that the sodium should not be excessively concentrated. Is it clear? So that's the thing. So and also bicarbonate is very important here, because you need to know that in diabetic ketoacidosis there was also loss of sodium ion. So you're also replacing indirectly sodium ion by using bicarbonate. Is it clear? So the next one is the potential danger in administering bicarbonate. What's the potential danger in administering intravenous sodium hydroxide, sodium hydrogen carbonate? You need to know that it can result to an overshot high alkalosis once the ketones are metabolized. So it can directly result to an acute alkalosis because of the hydrogen carbonate ions. It can result to increase affinity of hemoglobin for oxygen, leading to tissue anoxia. So is it clear? And the next one is that temporary worsening of cerebral acidosis, a sudden increase in blood pH. So you have a sudden increase in blood pH going to abolish the hyperventilatory drive, because you know that there was a hyperventilatory drive that resulted to acute small breathing. Is it clear? In the respiratory center, that changes the blood pH. Now in this case, when there is that abrupt change in the pH of the blood, when there's abrupt change in the pH of the blood, there's going to be cerebral paradoxical fall in carbon dioxide. Is it clear? So there's cerebral paradoxical fall in carbon dioxide, which is going to abruptly stop the breathing and increase hydrogen carbonate in blood. So those are the different things that is going to occur. Now, hyperosmolar non-ketotic coma now is the next disease, acute disease, that you're going to visualize here.